we ready? Are we already broadcasted? Yes? Okay, good. My name is Martin Walter. I'm one of the 6 speakers of the newly funded DZPG. I'm speaking for the site Jena, Halle, Magdeburg, and together with Claudia Schilling, I will be moderating the next session that addresses contributions from the DZPG, being one of the 2 new kids on the block, so to speak, in the group of the German health centers, together with the Child Center. We had a little bit of limitations, mainly funding-wise, which meant we had to be a bit more moderate or modest in what we can do. But one big opportunity was that we were funded, or we were selected in 2021, which means the evolution of our center basically happened in parallel to the pandemic and to the definition or the concept of the post-COVID syndrome. And that might have some advantages also that helped us to strengthen certain research foci or research tools that we actually strengthened in their priority in our research agenda. And I think this is what helped us a little bit to already bring in some first evidence results, but also we will report on studies where we engage as a center to also acquire for additional third-party funding, but bring in the potential and the possibility of a German research center. So it's my big pleasure to introduce our first speaker, Dr. Tarek Jebrini from the Munich site, Munich-Augsburg. To be more precisely, Tarek Jebrini is a medical doctor working with Christina Adoyan, and he will be presenting one particular focus of post-COVID research, which really addresses the care, the translation aspect towards patient service. And it's my big pleasure. I don't see Dr. Jebrini, I see him now. Please give us our first lecture.
Thank you very much.
Sorry.
If it's okay, I would use it. So this should work. Thank you very much for the warm introduction. My name is Dr. Tarek Jebrini. I'm a postdoctoral researcher at Deutsches Zentrum für Psychische Gesundheit in Munich, Augsburg, and I'm a psychiatry resident at the LMU Munich, and I have the pleasure today to present you our data of the interdisciplinary post-COVID study, and with a focus on ability to work. So we jump a bit back to, so I have nothing to disclose. Just briefly where our data comes from, we have an interdisciplinary outpatient clinic which works intersectional. In the key focus we have consultations. We get our patients from screening of our primary healthcare network, and we of course work with different specialized departments like the cardiology, but of course the psychiatry where I'm based, and we focus mainly on healthcare service research. So very briefly here in an overview, the top 25 symptoms of our patients, and this is basically in line with the previous presentations. We see fatigue as being one of the most prevalent symptoms, as well as memory impairment, and of course on the psychiatric side, anxiety and depression with prevalence between 27 and 30%. Also in line with the previous presentation, we see that the majority or the biggest group of all patients are between 18 and 45 and female, which of course could be related to the comment before. Here you see the top 25 symptoms stratified by different groups, age and sex groups, and you see the lighter the color is, the more frequent the symptom is. So you see fatigue was the most prevalent symptom above all groups, but especially prevalent in patients with female sex. We also tried to stratify this in a correspondence analysis, and you can see basically the points which are more connected to each other are more likely to occur together. So we also see that fatigue and depressive symptoms are generally occur across the different patient groups. So I think we lost the Zoom connection, but I will just continue. Okay. 1 second, I have to put this to side. Okay. So basically regarding our diagnostic procedures and results, you see an overview here, and you can see that the laboratory results in our clinical everyday practice were around a fifth of the parts abnormal. With the ECG diagnostic, it was definitely less frequent, and we see, especially regarding the neuropsychological testing, that we have quite a lot of abnormal results. We do not see many normal results, but a lot of borderline results, which is also in line with the prevent. Sorry, there's something with the Zoom. Yeah, I think it should work now. Just popped up. Sorry for that. So to jump directly to the key study, the ability to work study, we tried to predict ability to work or inability to work 12 months after baseline. And basically to do that, we included the data of 295 patients, and basically basically, you see here the comparison of the baseline parameters. You see that there was a significant difference between the quality of life between the two groups, between the depression rates, and also regarding the lipid profile and the inflammation profile. Perfect. Here you see the slide which you should see, and taken together, we managed to predict the outcome of workability 12 months after baseline using a random forest tree model, in which we trained the model with 147 patients for the training data set, and the validation with 73 patients, and we selected 9 clinical parameters, which were the hospitalization during acute infection, the WHO severity of acute infection, so the symptoms at baseline, the prevalence of somatic comorbidities, the prevalence of psychiatric comorbidities, the age, the height, the width, and the Karnofsky index. And just to make sure, a random forest tree model is basically a multiple decision tree. This has nothing to do with a neural network. And so we did see quite encouraging results for our outcome prediction. We saw that the model had predicted the outcome with an accuracy of 0.75 and an area under the curve, which is basically the parameter of evaluating this model, of 0.756, which you see in the blue curve on the right. The most important key predictor was the Karnofsky index, which is basically a parameter for functional impairment. So this is very important to point out. We also tried to assess the perception and of the patients, as well as the clinical stuff. So we compared the severity of disease regarding general health, mental health, and physical health. And you see patients rated their disease as more severe and rather attribute the severeness towards physical health, while internists overall rate the severity of disease as being less severe and rather as being psychiatric, while psychiatrists usually would rate them as being rather somatic than the internist colleagues. Similar patterns we see for the severity and the perception of pain. We did also conduct a comparison of neurocognitive impairment with standardized tests like the D2 concentration test, and there we saw, which was in line with the presentation before, that working memory, attention, and concentration was mostly affected, but pathologic cutoffs were only exceeded in a few cases, and severe neurocognitive impairment was associated with depression, fatigue, and reduced quality of life, as well as a higher prevalence of psychiatric illness. So, to sum up, prolonged work inability we were able to predict prolonged work inability by clinical parameters. Subjective functional impairment did play a key role and should specifically be addressed in treatment. And overall, we saw diverse symptoms often without a clear somatic correlate. And overall, we saw a few pathologic somatic findings, frequent but slight decrease of objective neurocognitive test performances, and a big difference, actually a substantial difference in the perception between severity, perception, and neurocognitive impairment as a subjectivity and objectivity gap. And overall, a high prevalence of comorbid psychiatric diagnosis, which really underlines the importance of dual assessment for somatic and psychiatric treatment. With that, I want to thank the team a lot of the post-COVID ambulance, Dr. Christina Dojan and Johannes Burger, and of course Hans Stube. And thank you very much for your attention, and I'm happy for discussion and questions.
I think we're now offline, which gives us even a bit more time to discuss questions from the audience. Thank you very much for the interesting presentation. Are there already questions that Dr. Jebrini can answer? We still have time, up to 3 minutes. I may start then. I was seeing your impressive findings, and I was also reminded by one of the first talks today where participating in a rehabilitation program was actually a negative predictor of outcome. And I was wondering, given that you have these large data, did you have the opportunity to also include this factor in the patients? Because I think your patients come to a post-COVID center and they should come there regularly.
Thank you very much for this important remark. We usually see our patients in an out-clinic setting, so usually our patients would be seen before being actually referred to a secondary hospital. So usually our patients were in line before that, but this would be definitely an important aspect to include in the estimation. But usually our patients have not been in this treatment yet. So, but I think this is really there's probably a strong correspondence to the everyday impairment which we assess using the Kanofsky index, which we see is a very strong predictor for work inability.
Thank you very much. Are there more questions from the audience? This does not seem to be the case, so I think we are in the position to make up some time. Thank you very much for a nice presentation. Then it's my great pleasure and honor to introduce my co-chair, Dr. Claudia Schilling from our site in Mannheim. So it's Mannheim, Heidelberg, Ulm, as we call our DZPG sites by the full name of all participating universities. Dr. Schilling is a psychiatrist and a sleep expert, and you will also focus a little bit on the mechanistic component of our research agenda, and you will be today talking about a project that was also co-funded or actually applied for with a little bit of support from the DZPG. Claudia, we're looking forward to your talk.
Thank you, Martin, for the kind introduction. I'm happy to present to you today our currently just starting joint project, which has been funded in the round by the BMBF call about ME-CFS pathomechanisms. So we are focusing on sleep, contribution of sleep-related biomarkers to the pathophysiology of ME-CFS. So why sleep? First, as we already heard a couple of times, sleep is one of the most prevalent symptoms within post-COVID condition. Here we have two epidemiologic studies. One is the ICO study, a multi-center European study, and here you see that insomnia is a very prevalent symptom, with half of the subjects having post-COVID presenting insomnia symptoms. And we also see there in this ICO study that it's not only about insomnia, but also we have different kinds of sleep phenotypes. Here we have excessive daytime sleepiness with more than 30% of prevalence. And in the epilogue study, of which we already heard this morning, we also see a similar picture regarding insomnia prevalence. We also see about half of the subjects having insomnia symptoms. And in this study, we have been in the position to differentiate between previously already existing insomnia symptoms before the infection and newly occurring symptoms. And as insomnia, of course, is a very prevalent symptom or condition in the general population, we see that it already has existed in a lot of patients before the infection, but still we see that most of this high prevalence of insomnia morbidity within the post-COVID group has been newly occurring, more newly occurring than previously existing insomnia. Now again, why sleep? Sleep serves a lot of very important functions. It's important for regeneration of the brain, of course. It's very important for cognitive processes and, of course, also for the immunological balance. But here in our study, we focus on a different aspect of sleep. We see sleep as a tool, sort of, to use it as a window to brain function. Why that? I want to focus here on two networks, which, in my opinion, are interesting, especially with regard to post-COVID or to ME/CFS also. That is the thalamocortical network, of which sleep spindles and oscillatory EEG activity is it's a very prominent EEG pattern in sleep, and that is the substrate of this pattern is the thalamocortical network. And it has a very important role in sleep stabilization and also in memory consolidation. And this network during waking has an important role in sensory stimulus processing. And on the other side, the brainstem offers a couple of phenotypes during sleep, which are also interesting to look at, because we have sleep-related breathing regulation, which is often impaired in post-COVID and ME/CFS, and we have very often autonomic nervous system control dysregulations, which we all know is a very often observable symptom in post-COVID, and we have arousal regulation, for which the brainstem is important. So we see that here we have two networks which are related to symptoms which play an important role in this syndrome, this condition. So what about sleep? What do we know about sleep phenotypes in post-COVID or after COVID in general? We have a couple of polysomnographic studies already. Lots of them focus on sleep-related breathing disorders. But we, until now, already have a couple of others which saw different kinds of phenotypes, also hypersomnia symptoms, which are not so very prevalent in the general population, but here we see them a little bit more often. And we sometimes have reports about REM sleep without atonia. And if you see the whole picture, we have a high prevalence of sleep-related breathing disorders, a high prevalence of insomnia, and quite high prevalence regarded with respect to the general population with hypersomnia syndromes. And in our own study with 40 patients and 40 controls investigated with polysomnography in our sleep lab, we saw, regarding the diagnosis of sleep pathology, we saw also a picture of heterogeneous phenotypes. We had as an inclusion criterion that the subjects did not have to have, they were not allowed to have sleep-related complaints before the infection, and there had to be absence of psychopharmacological medication. So we saw, as reported, a high prevalence of insomnia again, and a high prevalence of sleep-related breathing disorders, and also hypersomnia syndromes and a little bit of restless leg syndrome. We then wanted to investigate into this relevant networks with a focus on sleep spindles, and we saw a significant difference in sleep spindle density with less sleep spindles in the post-COVID group compared to controls. This spindle deficit correlated with cognitive functioning in a test battery, and it also correlated with an endothelial marker of oxidative stress. This was MDA, malondialdehyde, which you see here in the graph. That is preliminary data. And regarding this MDA, we also saw group differences, and our spindle deficit also correlated with ACE2 antibodies. So, and now in our currently starting study, we want to follow this path and look deeper into the sleep phenotypes, also into the sleep-related breathing phenotypes, and then relate these sleep-related findings first to relevant clinical outcomes, and then on the other hand to pathophysiological investigation. And with that, we focus on the hypothesis of vascular mechanisms. In our previous study, a subgroup of these patients, which I reported already regarding sleep, a subgroup of them was also investigated with MRI, with magnetic resonance spectroscopy, phosphospectroscopy, and there's the same background that we have the hypothesis that there's a damage to the microvascular system and endothelial cells, and then coming to tissue hypoxia and mitochondrial dysfunction in the end. And in this study, we looked at 27 post-COVID patients and 23 healthy controls. They were all after mild acute infection and had a Bell score of around 50. And what we saw here is a significant difference in the ATP level in a very big cluster around the cingulate gyrus in patients compared to controls. So the hypothesis of probable mitochondrial dysfunction with deficit in high energy phosphate metabolism was supported by this data. And this deficit in ATP correlated with cognitive functions. Here I showed you the MOCA results, and it also correlated in the TMTB results. So we, in our currently starting study, we want to do that also, but with 7 Tesla. And in addition to that, we do vascular imaging with ASL, that in 3 Tesla, and we combine this phenotyping of the sleep phenotypes with this imaging, and then with blood-derived vascular biomarkers and with polygenic risk architecture investigation for vascular morbidity. We are going to do this in 75 patients with ME/CFS and 75 controls, and we complement our adult cohort with a pediatric cohort, and that is important for several reasons. One is that the pediatric cohorts and also the severely affected cohorts are often neglected, and we wanted to not do that. And we have the possibility to work with a group of inpatients from a pediatric hospital, which are really severely affected, around Bell scores between 20-30 on average. And the pediatric cohort has another advantage. They are, as they are young people, they have less morbidity regarding COVID-independent vascular diseases, and so as we want to investigate into vascular mechanisms, it is good to have a group of patients which are healthy with respect to this kind of mechanisms outside of COVID. And as they are heavily, severely affected, we needed to find a solution to investigate them. We also make a longitudinal aspect. After years, they are investigated again. And in the first baseline investigation, they are in hospital. But then later on, we wanted to investigate them at home because they would not be able to come into a sleep lab. And so we are working together with the Fraunhofer Institute, and they provide us with a mobile EEG assessment possibility. And the cognitive assessment can also be done remotely. So our aims from this SLEEP-NEURO-PATH study are to relate the sleep-related phenotypes to relevant clinical aspects, relevant health outcomes, like cognitive dysfunction and fatigue, central nervous system outcomes, and then to investigate possible underlying neurobiological mechanisms. And this aligns with key pathological concepts of endothelial dysfunction and mitochondrial dysfunction with a background of microvessel pathology in MECFS. And with that, we want to contribute to a better understanding of the pathophysiology of MECFS and with respect to the sleep changes seen very often in MECFS, and see how this relates into relevant health outcomes, and maybe whether we can see clinical phenotypes as subgroups in MECFS which may be related to different sleep phenotypes. Okay, and with this I'm at the end. I here show you the partner sites with who we are going to do that. That is the University Hospital Schleswig-Holstein Campus Kiel, and we at the CIMH, and the Children's Clinic is a Marine Hospital in Wesel, North Rhine-Westphalia, and then the Fraunhofer Institute in Oldenburg, which provides the mobile EEG technology. And then I thank you for your attention, and of course also the many patients without whom that would all not be possible, and for the funding by the BMBF. And I'm happy to take questions.
This is funny, I can't see myself on the video. So obviously I'm a vampire to the audience. I hope I will be seen in a moment. Well, thank you very much for the very interesting presentation. As we don't have hands raised in the audience at the moment, I would like to start with questions from the online participants. Past CFS studies found increased slow wave sleep and microarousals and decreased infra-slow power. Did you see the same considering trialing baclofen, gabapentoids, clonidine to fix changes in sleep architecture?
Okay. The latter part of the question related to medication. If I got that right, I cannot answer that because in our group they all have been without any psychopharmacological medication. But left that apart, we did not see raw sleep architecture changes if we take out all those who have sleep-related breathing disorders or restless legs, periodic limb movements in sleep. If we only take the pure others, then we did not see sleep EEG changes except our spindle deficit and except hypopneas. We did see quite a lot of hypopneas even in those who did not have sleep-related breathing disorders, and we do see them also in lean female patients, so in those who are not the typical risk profile group of sleep-related breathing disorders. And that's, we want to look into that more deeply because we suspect that that might be a central nervous origin problem.
I hope this answers the question. Thank you very much. Is there another question from the audience? I would have a related question. I mean, how representative is the sample that you're investigating, considering that you're not looking at any medicated patients, particularly considering sleep? I would imagine also in your post-COVID center, you observe a lot of patients who have at least tried sleep-improving medications before. So is that like a small group that are really unmedicated?
No, not really. Quite a lot of patients did try a medication before and then left it again. So it's not difficult to get this sample.
They are currently unmedicated.
Yeah.
Okay. Good. Then we are still able to make up some time. Thank you very much again for the nice discussion. And then I hand over to Claudia Schilling as the chair for my last talk.
Continue with Martin Walter.
Yeah, thank you very much. I've introduced myself already. I think I can use this microphone. And yes, I will present another study that is basically run and applied for by the DZPG together with colleagues. I already mentioned that we could confine our research areas during the institution or the setting up of the DZPG, and we brought in some, I would say, complementary expertise which are genuine to the research of mental health that, of course, start from mental physical interactions, brain process particularly, not only imaging but also imaging the modification of brain processes, and very importantly social stress research, which is the basic foundation also for mental health. And in the field of mental health research, passive observables such as wearables, but also ecological momentary assessments play an important role. So they have already been part of our research portfolio, so to speak, but they also put up us in a position to really investigate post-COVID related changes. In our last meeting in Berlin, which was I think the first DZG post-COVID meeting, I presented to you the brain imaging data in addition to what Claudia Schilling has presented today. But today I would like to emphasize another modality which we realized that the research really could make a difference from a mere scientific investigation to something which has a lot of translational potential. This is the wearable or digital mental health assessments you see here in the lower part, because here we feel that in the patient population these tools are well known, heavily used and discussed, but we quite seldom see it that a patient goes to the primary care physician with his smartwatch or with the Garmin body battery symptoms, and the doctor could really talk to the patients. So here patients currently bring in a lot of information which currently is not used in clinical care, although they may bear important information. That's why we set up a consortium consisting of partners from the DZPG and additional partners, which I will introduce in a moment, in the BMBF data call in 23, and we got funded. And here our aim was to create and develop longitudinal profiles of post-COVID patients, and also to identify disease-specific markers. And here our focus is also relating to Claudia's talk on sleep, heart rate, and physical activity, because there can be nicely passively assessed, and also bring in then the combination with subjective patient assessments such as stress or perceived fatigue. How would we like to do this? Well, here we plan to integrate extensive epidemiological databases. The call was on existing data, so it was not the purpose to generate new data, but of course bringing together post-COVID centers that are co-harmonized by the German Center of Mental Health. We have it easy to also use data exchange infrastructures from the DZPG for exchanging or pooling data. We also had data from non-clinical stress conditions, also BMBF funded. We have, of course, a large set of psychiatric cohorts. That's very important, because in the field of post-COVID, there is always the big question, how much of the post-COVID is actually related to genuine psychiatric diseases, or is it just a comorbid spectrum. So here we bring in, I think, a central competence to say this is really a depression or this is a depressive symptom as part of a non-depressive post-COVID condition. And we also were lucky to bring in health app data from more than 5,000 patients who download those apps because they suffer from fatigue symptoms, and then they track their everyday fatigue symptoms, for example. Then we combine this with use of self-learning AI methods, which are developed in parallel at the DZPG, and the big aim is to use those particularly for long, high-resolution time series, which really allow us to create clinical subgroups on the level of dynamic markers. So that's, I think, something methodologically speaking innovative, and also then to use those markers because we have those long time series of up to 2 years of data, high-frequency data, also to test for prognostic value. This all should serve the purpose to develop variables as a new clinical data modality, which particularly for post-COVID, but also I think in many other psychiatric conditions would be something new. We are aware that in, for example, cardiology, first FDA-approved smart devices are already making the progress towards translation, but for us, and I think also for post-COVID, this would be really a game changer. And of course, this whole initiative also should test how an interface between the German Health Center and other scientific initiatives outside the German Health Center could actually work. What's the methodological innovation? We, I've already mentioned this, feel that we can really collect and make usable data that is currently in the system but not really used. We have the big problem of data quality. So as soon as you go to real world, science normally ends where real life starts, and this is something which we have to overcome. Really adding to the translational purpose, we have to make use of best quality data, particularly from sensor data or from sleep data, Claudia has shown, and then bring them into a format which is compatible to what we observe normally in large data cohorts with a lower granularity normally. And here we introduce the service of generative models which can generate low-level or low-quality data, which is based on observations which come from high-granular data, for example, from PSG polysomnography to start with. We also were happy that we can introduce patient-centered information, particularly from the subjective dimension from EMA, which are collected already, also part of approved DIGA tools, and then also take this information outside the group that considers themselves as patients toward a more general populations. And you probably are aware of the data donation app, the Datenspende app, which was very successful and collect a lot of data over years from patients. Here we're talking of data in the dimension of up to 500,000 individuals who collected for longer time periods not only their heart rate or their subjective experience, but also many of them also handed in the test that they did when they did a COVID test. When the test was positive, we can actually then look at the evolution of those observables after the individual positive COVID event. So how is the project designed? We bring together multidisciplinary expertise from the different DZPG sites. So here from the psychological and psychiatric dimension, this has a strong focus in sub-project number 1 with Malik Bashbush and Annette Rose from Berlin, where they also bring in NUM-generated data from the Kolpan consortium, which is, I think, can you stop it? I think I forgot to reset it. All right, now my timer has stopped and I can give a good talk. I will run through the other sub-projects very quickly. We also rely on expertise on sleep, basically particularly by Claudia Schilling, who then connects with other post-COVID experts from Munich, Christina Adoyan, for which Tarek Jebrini has presented data today, and then connect this clinical expertise with more data science expertise, both on the level of how do we orchestrate multi-center or federated analysis of data, and also what types of methods do we apply. And here in project number 4, we do have experts on dynamical systems reconstructions, particularly for normative forecasting. I will go into detail in a moment. Basically, the task here is to develop an NFO. This is a neural flow operator method to basically generate models that then can produce data which resembles the data that we observe in clinical reality. And then, luckily, we could team up as the DZPG with Dirk Brockmann from Dresden to then bring these observations into real-world data outside the clinical world. Yeah, how do these projects look like? In project 1, I mentioned we are looking at data that come from psychiatric patients. Here we consider depression not as one disease, but already depression itself is a set of different entities, and we rely heavily on EMA that monitors stress or affect parameters in their dynamic evolution over time. And this method, which is already developed and implemented outside post-COVID, which is basically prone to detect subgroups of patients based on dynamical profiles, we feel is very helpful also to discern post-COVID patients who have depressive symptoms, but are not depressive patients by definition, also from those which happen to have depression as a true diagnosis in addition to a post-COVID condition. This is why we feel this is important. I basically step over the presentation of SLEEP project number 2 because it's very closely to what Claudia has already shown. In sub-project number 3, the idea is to really improve the differization of data or make data most available not only within the consortium but also towards other consortia. This is something that's an ongoing effort which needs to be also specified for the specific data modalities of variables. And here we can also bring in some strengths of the DZPG, for example, the cohort mapping or the meta-cohort mapping that's part of one dedicated infrastructure. We have a dedicated infrastructure on federated cohort mapping. And here, if you go to the DZPG, you can really look in such databases. You can first see, I want to see all studies which use smartphone or wearable-based data, and then this mapping gives you the name of the cohort, the type of diagnosis these data were collected, and at which sites you can find how many data sets or studies related to this entity. So we feel this is helpful, but in addition to the DZPG located data, we also brought in data from outside the DZPG. Namely those BMBF-funded unhealthy participants, such as from the Cello Consortium, a lot of DFG and EU-funded studies on people with psychiatric disorders. As I said, this is important for differential diagnosis, but then also a lot of data from people with actual long COVID symptoms. Most importantly, also here you see quite big numbers from FEMO Health on self-diagnosed post-COVID. And then, importantly, going big data in really large data sets where we want to see how many of these descriptors would identify individuals in a population which initially was not clinical. Here then, sub-project 4 would actually develop normative models based on sleep data, but also on brain data. These normative models are normally designed cross-sectionally, so at the different time points you look at changes of certain parameters, but importantly here, the big methods development would be to generate dynamic systems reconstruction for normative forecasting, which means that instead of a one time point assessment, you learn the underlying dynamics in a certain modality, which is then characterized by a numerical representation of a model that then generates behavior that resembles the true observation. And importantly, this cannot only be done in one modality, but currently there are efforts to generate multimodal generative models that actually produce so to speak, digital twins of the real world, but also allow us for testing, forecasting possibilities of dynamical properties that we can then investigate in patients in greater detail. This is something which adds to something that already works. So going really large data, here 500,000 individuals that track, for example, their heart rate or their steps, and also give us information about when they received a positive COVID test. We already see that in principle there is a lot to gain from these data. So here, having large data, you can also be quite picky. So from 500,000, you go down to individuals that either were COVID positive or COVID negative. So within those 8,000 individuals, you can still then, based on their EMA criteria, say if they were actually COVID positive or post-COVID positive or negative, and then you can even select those subjects which have the best data quality, in this case more than 100 heart rate measures subsequently to look for ongoing dynamics. And then for non-post-COVID, post-infected versus post-COVID, post-infected individuals, you can compare, for example, the heart rate after the infection But you can also see, for example, for a non-affected individual where the step count returns to normal after at least 6 weeks, where there seems to be a change in step count for the post-COVID assessed individuals in parallel. And this might look a little bit counterintuitive that, for example, the heart rate looks down if you look at individual data, but you can also, of course, group the data, and then you see an increased heart rate, not only after the COVID infection, but interestingly also before. And here we are very interested to see how the dynamic exploitation of this data will lead to further insights. So to sum up, the DZPG can bring in some expertise that helps to quickly exploit existing data and connect databases for greater analysis or connect expertise from different areas to exploit it in one data set. We also are able, based on the clinical sites that are setting up the DZPG, we bring in about 250,000 patients in our clinical entities that can be investigated also by broad consent solutions. And I think quite helpful is the decision of the DZPG to distribute the responsibility for a number of infrastructures that then can step in at a moment for specific new questions that arise, such as it was the case for this BMBF data call. So thank you very much for your attention. Looking forward to your questions.
Yeah, thank you, Martin, for this nice talk. Are there any questions from the audience? No? No? Yes, there's a question. There's a microphone.
This might not be a typical question for the colleagues here today. I'm the father of a ME/CFS patient. My daughter is 26 years old, and the biggest problem we have right now is coordinating day-to-day life for her because of her sleep rhythm. I've heard a lot about the research you've done, and I find it wonderful that it's being studied. Do you have any light at the end of the tunnel with regard to treatment and therapies that could be implemented starting now, perhaps even in the form of taking part in a study? You mentioned medication that stabilizes the sleep aspect. Everything you guys discussed and showed today, she has. I've been able to observe it in the last 7 or 8 years. I'd love an answer to my question, if you have one, please.
Okay. You are speaking about sleep problems, not ME/CFS in general. One of them, yeah. Okay. Okay, we do have working treatment strategies for most of these sleep problems, but we don't know yet whether the treatment works as well as in these conditions outside of COVID. For example, insomnia, we have a very well working treatment. Cognitive behavioral therapy for insomnia is a first-line treatment, and also medication, second-line treatment then. But we do not know whether this kind of insomnia within post-COVID, which newly started in post-COVID, if it reacts in the same way as outside of post-COVID. There are studies running right now. There's a study about CBTI in the US. I'm a little bit hesitating about doing CBTI in insomnia within post-COVID, but there's no data where we can rely on that. We need to study that. Yeah. Mm-hmm. And with other disorders, that's the same. Like this hypersomnia, we do treat symptomatically with stimulants. If there are no more questions, then we can catch up with some time and start our lunch break.
So, at best, all the juniors queue up here. I prefer to queue up there, okay. In order to be really quick, we have only 3 minutes, you know the rules, and there won't be questions, or questions will be reserved for the break, but it's just a quick view of the best junior science. So we had several applications, so we had to bring it down to now these juniors who are queuing up here, and we go right ahead. And the first one is Julian Wagner from Frankfurt, cardiac fibrosis and innovation in long COVID, the role of pre-existing pre-existing cardiovascular disease.